Hi everyone, this is Dr. Jacob Pace.
And I am Dr. Samir Mall.
This is a screencast outlining the LHSC Emergency Department COVID-19 Airway Management Strategy.
Jake and I recommend that you have the corresponding Emergency Department Airway Management flow sheet as well as the equipment checklist handy for reference during the screencast. Ultimately, although this is a very anxious time for everyone and we are jumping into a high-risk procedure, now more than ever, it's important to keep things simple. This is a nice infographic that Jake and I have sourced from the Canadian EM website, thank you to them, which goes through some of the big highlights. On the left side of the screen, what are we going to do? Well, number one, protection of yourself and your team is of the utmost importance. Use airborne precautions with an N95 mask, fluid-resistant gown, long gloves, and a face shield. Try to do this procedure in one of your isolation rooms whenever possible. We're going to use an RSI type technique so that we're limiting coughing with the patient and any potential aerosolization of virus. And we're going to use video laryngoscopy so that we're standing nice and far away from the patient's mouth.
Things to avoid: high flow oxygen. Avoid things like BiPAP, nebulized therapy, high flow nasal cannula, or really anything above 6 liters per minute when possible. Don't allow non-critical staff in the room. Avoid bagging a patient, but if you feel that it's critical, do so with a two-hand technique to achieve a good seal and ensure you have a viral filter on your BVM. Avoid prolonged intubation attempts. The best way you can do this is allowing the most qualified and experienced provider to do the intubation and using the quickest technique available to them. Avoid open circuits at all costs. Ensure you have a viral filter between the patient, whether that's a BVM, face mask, endotracheal tube, or LMA, and the oxygen source, and make sure that you clamp that endotracheal tube if you're going to disconnect to switch between a bag and a vent. Finally, keep everybody safe. Don't bring used PPE outside the room.
This is our LHSC Emergency Department Airway Management flow sheet that Jake and I have created. We essentially adapted the LHSC Critical Care Department's airway management strategies in COVID patients and distilled it down to what is required specifically in the emergency department. We'd like to thank the UK College of Anaesthetists as well as the Intensive Care Society in the UK for the general design of the slide. Don't worry about memorizing this right now. Jake and I will be going through each step from left to right, but if you do have it open for reference, that would be very valuable. It will be posted in multiple different places throughout the emergency department, including the isolation rooms and the resuscitation room, and there will also be handouts available for reference if you are about to attempt this procedure.
So starting on the left side of our flow sheet, the first 3 boxes all occur outside the room. The first box is regarding preparation and PPE as well as location. First thing we want you to notice is that if you have a planned intubation, please pre-notify the ICU so that you can immediately transfer the patient out of the emergency room once endotracheal tube is secured and it's safe to do so. Next is location. Your preference in terms of where you're going to be locating these patients is first a negative pressure room, or ISO rooms at UH, the 2 of them, or your single ISO room at Victoria Hospital. If we run into a situation where the ISO rooms are full, which is more than likely to occur in the next coming weeks, a private room with a closed door is the next preference, followed by the resuscitation room. And finally, you may even consider deferring intubation to the ICU if that is the patient's trajectory of care.
So ultimately, with respect to your team members, you want 3 expert operators in the room who are all in airborne precautions. It's beyond the scope of this screencast to go through the appropriate donning and doffing procedures for airborne precautions, but there are lots of resources available online, and the one on this slide was distributed by our chiefs for reference. So check each other to make sure everyone's PPE is appropriately applied. And just very quickly, airborne precaution PPE requires multiple elements like a head cover, face shield, goggles, an N95 mask, level 4 waterproof gown, and long gloves. Although this picture does not show a neck cover, their LHSC is currently looking into easy disposable solutions for neck covering, as that is a high-risk area for contamination.
The next member of your team is going to be a runner in the ante room who's in full airborne PPE, who's available to retrieve equipment that you do not have in the intubation tray, which we'll review shortly. And finally, you're going to have one runner outside the room. This picture does not have the runner in any PPE. In retrospect, we feel it's best if this runner is in droplet contact precautions.
So going on to the next part of our flow sheet is our equipment. And this is where our equipment checklist comes into play. So this equipment checklist contains the minimum necessary standards to perform a safe RSI. We have developed a separate COVID intubation tray that contains much of this equipment. That plus the equipment that is in each isolation room, stocked in a standard fashion, should together equate to a full set of equipment. However, independent checks are necessary, as it's often easy to forget small pieces of equipment, and it is easy for things to go missing. So we do highly recommend that you take your time and go through this checklist once you're in the room to make sure everything you need is actually there.
We want to go through some of the elements of this checklist. This picture is really to demonstrate why we feel that non-rebreathers and standard face masks are unsafe, and if avoidable, we'd prefer that. There's been studies that look at air dispersion at different flow rates using different methodologies to detect air dispersion. This picture shows that on 15 liters per minute through a non-rebreather, you can expect air dispersion to occur about half a meter in both sides of the patient. So we don't want to avoid this massive amount of air dispersion, as obviously this is unfiltered air, which could likely contain viral particles. Our recommendation is to use a Flow 2 Max. This is a non-rebreather device that we have at both Victoria Hospital and University Hospital. The concept here is though there is no exhalation or expiratory vents on the sides of the masks. Both the inspiration and expiration ports are at the bottom of the mask, and the expiration port is filtered through a viral HME filter. One note that the Department of Anesthesia has recommended is that sometimes a nasal bridge doesn't provide a great seal. They've found that applying a single piece of tape can help with that seal. So if you're using this mask and you feel that the seal around the nasal bridge is not ideal, please apply a piece of tape to help facilitate that.
Going further into equipment preparation, we have our oxygen flow regulators here on the walls of the isolation room. We want to set our nasal prongs to a max of 6 liters per minute, 6 liters or less, to minimize aerosolization of virus. And we also want to set our Flow 2 Max non-rebreather at 15 liters per minute, again, just to keep the team as safe as possible. All in all, you're going to need 3 oxygen sources. Most of our isolation rooms and private rooms only have 2 oxygen flow regulators on the wall, so please use a oxygen tank on the bottom of the stretcher as your third source. So your 3 sources of oxygen will be 1 for your non-rebreather, secondly for your nasal prongs, and thirdly for your BVM.
Because these intubations will be taking place in non-typical care areas for intubation, we develop an intubation tray. These are the same at both sites at University and Victoria Hospital, and the contents are listed on top of it. These will be stocked by our ED technicians in the department. What you'll find when you open the box is first the flow sheet and our checklist attached to the lid. And then you're going to find the same list of equipment in both trays. It's important to recognize that not everything on the checklist is in the tray. Some of these items have been stocked in the isolation rooms. So it's important to ensure that you do have everything on the checklist and not just relying on the tray to have everything in it. This is all the contents of the tray laid out. You can see there's multiple sizes of LMAs, endotracheal tubes, nasopharyngeal and oropharyngeal airways. There's a PEEP valve, an HME viral filter, end-tidal CO2, direct laryngoscopy with multiple sides blades, as well as an emergency cric kit and a tube holder. We want you to bring this tray into the room. We've been reassured that as long as the packaging is not open on any of our equipment, it can be wiped down safely for reuse. You are not wasting this equipment if you're bringing the tray into the room with you.
This is a nice circuit infographic that Jake and I found online on the First 10 EM website. And essentially this is just a simplification of how we want our circuits attached from the patient to the oxygen source so that your team is staying as safe as possible. From left to right, you're going to have some sort of mask or endotracheal tube or LMA on the patient. The next vital piece of equipment that should be attached directly to that piece is the viral filter. And then going forward, your waveform capnography and your BVM as you would in any other case. Here it is with a BVM in our departments here. So you can see a face mask would be applied directly to the patient. The next piece of kit is the HME filter, which fits onto the face mask. And the rest of it should look pretty similar to you. From there forward, you have the waveform capnography and the BVM with a PEEP valve. So again, this is how we would like all of your BVMs set up.
Moving on to the third box, this is still preparation before you go into the room. You're going to discuss with your team your airway strategy in order to optimize your first pass success. The first thing, your first pass we recommend is video laryngoscopy. It allows you to stay as far back as possible from the patient's oral pharynx and allows good visualization of the cords.
Ultimately, if you are using video laryngoscopy and your patient suffers a critical desaturation, this is one big difference between COVID airway management strategies and a usual RSI, which you might do, is Jake and I are advocating rescue oxygenation with an LMA. This is because of the better seal that an LMA can potentially provide compared to a BVM. So remove your video laryngoscope blade, insert your LMA, and then blow up the cuff of the LMA. And lastly, the same apparatus you had attached to your BVM face mask, just take the mask off and the remainder of the apparatus fits directly on your LMA and you can perform rescue ventilations this way.
There's been a lot of angst about bagging these patients. We do want to emphasize that if you can achieve a good seal, it is safe to ventilate these patients through a face mask. Our preference is an LMA as it is more likely to give you a better seal. But if you are in a crunch and you need to use a BVM, it is safe to do so as long as you get a good seal. Our recommendation is a two-hand approach with thumbs down using your ring and middle finger to pull the mandible up into the face mask while applying countertraction with your hands while inserting an OPA plus or minus MPAs to help with ventilation. In each airway or intubation tray, you're going to find an emergency crite kit. If you have failed on your first pass and you are unable to oxygenate and ventilate the patient, you're going to be moving towards a can intubate, can oxygenate scenario, and you're going to be using an open crike. The contents of this kit are a bougie, a number 6 endotracheal tube, a scalpel, and a 10 cc syringe. You're going to be performing a scalpel finger bougie technique to an open crike. There's lots of resources online for you to review this technique. One question that we've had is, why is the only bougie in the crite kit? Do I need to open this if I need a bougie? The answer to that is no. There should be a bougie taped to the wall of the ISO room. The only time you should be opening the crite kit is if you are entering a crite situation. All of this equipment that you need for intubation, including a bougie, will be elsewhere in the room.
So just to summarize that third box of our airway flow sheet, when you're making up your airway plan, you want to start with VL so that you're staying nice far away from your patient. If your patient desats, try to oxygenate them with an LMA, ideally. If not, get a good two-hand thumbs down seal with your BVM. And then lastly, going to an open crike sooner than you may otherwise would in a non-COVID patient. So going on to box 4, we've got all our equipment, we're nice and protected with our team, we've allocated our roles, we got our plan. Now we're going inside the room, and what are we going to do? So let's go through each of these pieces individually. Number 1, your team outside needs to know what is happening with the intubation. So we do recommend establishing some kind of speakerphone contact. Both the isolation rooms and all the private rooms will have a speakerphone, and get one of your team members outside to call in so that they can hear what's going on in the room and be ready to get equipment for you when needed. With respect to patient positioning, this is the usual that you've seen in many other places. Keep your patient ear to sternal notch. We're hopeful that your COVID-19 patients won't also be trauma patients at the same time, but whenever possible, get your patient ear to sternal notch, and then get the head of the bed up to 20 degrees or use reverse Trendelenburg positioning.
We want to apply appropriate monitors to the patient. This is going to include ECG leads, a SAT probe, a blood pressure cuff on the contralateral arm to your primary IV. You want to ensure that you have some element of pre-oxygenation, ideally with a flow 2 max non-rebreather and nasal prongs, both set at of the flow 2 max of 15 liters per minute and the nasal prongs at max of 6 liters per minute. And then also have an IV running, an IV bolus running. In terms of hemodynamic support, again, the IV bolus plus or minus a levophed norepinephrine drip or having push dose pressors ready, as there have been reports that these patients do have cardiovascular collapse on induction. Again, your first attempt is going to be with video laryngoscopy.
All right, so you're going to do video laryngoscopy and ideally secure your patient's tube. So now we're going to our post-intubation management. So what happens here? Well, let's go through each of these steps. Number one, we're going to secure our endotracheal tube through the cords, and then we will inflate the cuff before you begin any ventilations.
You immediately disconnect, if you had a face mask on your bag, disconnect the face mask, and the rest of the apparatus stays the same, including the HME filter. You then take your HME filter and attach it directly to the endotracheal tube. And you'll see the setup here where you have your endotracheal tube in situ, next connected to a viral HME filter, the waveform end-tidal CO2, and your BVM with a PEEP valve.
We've had a lot of questions regarding portable x-ray. We do not advocate that these patients get a portable x-ray in the emergency department immediately after intubation. The ICU should have been pre-alerted that this intubation is happening about 20 to 30 minutes prior to this point in time, so hopefully a bed would be ready. We know our endotracheal tube is in the right place because we have waveform capnography attached. At this point, a post-intubation chest x-ray just doesn't provide enough value, and in our opinion, doesn't outweigh the risks of contaminating the rest of your team outside of the isolation room by having to open the main door of the isolation room and release the negative pressure.
In terms of post-sedation or post-intubation sedation, we would recommend using bolus dose sedation rather than initiating infusions. Don't forget, you're going to be using a full dose of a long-acting paralytic. These patients do require sedation as their paralysis will outlast the introduction agent. Once
your patient's endotracheal tube is secured, you've got some sedation pushed, notify security, and security will clear a path to the elevators to get up to the intensive care unit. We're currently working on different scenarios for the safest team to take that patient up to the ICU. For the time being, Jake and I are recommending that the team that does the intubation is the one that subsequently takes that patient up to the ICU so that we're not using more PPE for a new team to be involved just for that short transfer. Once in the intensive care unit, we cannot stress enough, please remember to clamp that endotracheal tube when you are disconnecting from the BVM to then connect the patient to the ICU ventilator.
We want to emphasize again, we recognize that this is intubation in the emergency room can be an anxiety-provoking procedure at the best of times. This is certainly amplified given the current crisis we are in. We hope that you find this resource helpful in terms of planning your intubation and doing it and planning it in a safe way. We also hope that this material is dispersed to both RNs and RTs so everyone is on the same page in terms of the strategies we're going to be moving forward in the next days to weeks to months.
Thank you very much, everyone, for taking the time to watch this screencast. If you have any questions, please don't hesitate to contact Jake or I, and we will continue to evolve our airway strategies as best practice potentially changes over the coming weeks and months. Thank you again.